So my name is David Wald. I'm one of the emergency medicine faculty here at Temple, and it's a pleasure to speak to you today about acid-base disturbances. And what we're going to spend a little bit of time, it's going to be a short tutorial, but it's going to be helpful for you to kind of gather this information, spend a little bit of time reviewing this topic before our lectures in February. And also this is going to help better prepare you for the workshop that we have scheduled for you through doctoring and also through Block 3 in early February. Now we have some learning objectives, just want to go over with you briefly here. The first thing and the key thing for this session here is really to provide you with an introductory review of basic principles of acid-base disturbances. And we're going to try to make this as clinically oriented as we can, but there's some basic information we need to kind of get across to make sure everyone starts on the same page. Now this initial kind of primer that we're putting together here is really designed to kind of start off and make sure everyone is kind of on the same page, that we can allow us to get really more out of the workshop and more out of the lecture that I will be presenting to you coming up in the next couple weeks. Now, if you take a look at some of the material that's out there, I mean, you can find hundreds and hundreds of articles and book chapters on acid-base disturbances. There are two references here that I think are really good, very practical, and help put this topic in some good perspective that I would recommend that you take a look at. This article published in the Western Journal of Medicine in 1991, and also a very recent publication in the New England Journal of Medicine provides, again, a pretty good background to trying to understand this material and also put it in a bit of a clinical realm so that it makes a bit more sense. Now, if we're going to start out here, we have to kind of make sure everyone's on the same page, and we're going to start out with just a few definitions and terms. And what you're going to hear, if you've not already heard these terms, are things like acidemia or alkalemia. Anytime you hear emia in reference to pH, we're really talking about whether the pH is acidemic or alkalemic. And the values that you will see listed here, 7.35 to 7.45, which is really the normal range of pH. But you will find certain textbooks or review articles that will list 7.37 to 7.42 or 7.43. There is a little bit of variation. There's probably not 100% absolute agreement or standardization, but at least for the context of what we're going to be referring to and what we're going to be talking about, pH of less than 7.35 will be considered acidemia. pH greater than 7.45 will be considered alkalemia. Now, when we refer to a particular process, that's where we use the term osis. For example, metabolic acidosis or alkalosis, or respiratory acidosis or alkalosis. So the osis really refers to a particular process. Doesn't necessarily tell you whether the pH will be acidemic or alkalemic, but it tells you that there is a particular underlying process. Now, to kind of get everyone on the same page again, there are four primary acid-base disturbances. There are metabolic processes, and as you can see, metabolic acidosis and alkalosis. And then there are respiratory conditions, respiratory acidosis and respiratory alkalosis. And if you think about it, if you are acidemic, your pH is less than 7.35, that's typically going to be due to one or another condition. And obviously from a respiratory standpoint, if your PCO2 is elevated, then that would be consistent with a respiratory acidosis. If you have a low serum bicarbonate, and that's typically obtained from a venous blood sample from a basic metabolic profile, then you would have a metabolic acidosis. So low bicarb, metabolic acidosis, high PCO2, respiratory acidosis. As a corollary to that, with alkalemia, again, pH greater than 7.45, that's either due to primarily a low PCO2, and remember your PCO2 is a value that's obtained from a blood gas analysis. It could be arterial or it could be venous, but it's again a value obtained from a blood gas analysis. Low PCO2, alkalemia, a high pH greater than 7.45 would be consistent with a respiratory alkalosis, whereas a high serum bicarbonate, again a venous blood sample from a basic metabolic profile, will be consistent with a metabolic alkalosis. Now these again are primary acid-base disturbances where the primary abnormality is either an abnormality with PCO2 or with serum bicarbonate. Now what you also have to realize is as this whole topic can get potentially more complicated, there are conditions where a patient can have what they call a mixed acid-base disorder, where you simultaneously have the presence of two or more of these simple acid-base disorders occurring simultaneously. Now there is a caveat, and the caveat ultimately is that you cannot have an acute respiratory acidosis and an acute respiratory alkalosis occurring simultaneously. You can have multiple metabolic processes occurring at the same time, and you could even potentially have a respiratory process also occurring at the same time. But think of respiratory acidosis as hypoventilation because your PCO2 will be high. And I guess you can really, in many ways, think of respiratory alkalosis as hyperventilation. So you can't hypo and hyperventilate at the same time. Now, again, from a metabolic standpoint, primary acid-base disorders, you have a primary change in your bicarbonate, and then the body will have a compensatory response. So a primary change in your bicarbonate leads to a compensatory change in your PCO2, which is respiratory compensation. That compensation typically occurs rather fast, over minutes to hours. And really what's most predictable is when you have a profound metabolic acidosis, when your bicarbonate decreases, you have a very profound respiratory compensation that occurs rather fast. Alternatively, when you have a primary respiratory condition, again, respiratory alkalosis or respiratory acidosis, you will then in turn have metabolic compensation, but that compensation is typically slow and evolves over multiple days. Now, this kind of really explains the relationship between PaCO2, again, just for the second, we're assuming an arterial carbon dioxide level, partial pressure of carbon dioxide, and bicarbonate, which is again from a venous sample. So if we go back just for a second and kind of look at this slide where it talks about primary changes of, let's say, bicarbonate and a compensatory change of a respiratory change, what you're ultimately trying to do, what the body tries to do, is it really tries to restore this relationship. So if you have a change in your bicarbonate, let's say your bicarbonate, because of metabolic acidosis, goes down, the body is going to in turn have a respiratory compensation and is going to try to lower PCO2 to restore this hydrogen ion ratio. Now, across the street in the hospital, we typically don't refer to aspects of the patient's condition as whether or not they have a high or low or an abnormal hydrogen ion concentration. We really talk more consistently about pH values, whether a pH value, for example, is normal, which is approximately 7.4, or if they're alkalemic, it's 7.5. But you can see the relationship that as your pH increases from 7.4 to 7.5, for example, your hydrogen ion concentration will decrease, and it's relatively predictable. Now, there are a few concepts that are going to be very important for us to understand, and we'll go over them momentarily, but it's going to be important, and this will segue into more of the clinical cases and really the way to apply this information clinically to determine what type of acid-base disturbances are going on with your particular patient. Now, the first concept we're going to talk about is something called the anion gap. Now, when we figure out the anion gap, when we measure this, it's really a calculated value. We don't actually measure the anion gap in whole. We actually measure components of it, and then we calculate the anion gap. So from a basic metabolic profile where we obtain data on, for example, sodium, potassium, chloride, bicarbonate, BUN, creatinine, glucose, calcium, lots of values that we obtain when we measure a basic metabolic profile. In determining the anion gap, the three important values are serum sodium, serum chloride, and serum bicarbonate. And what we do is we add the chloride and the bicarbonate together, and we subtract that from the serum sodium. And that value is normally accepted to be approximately 12. There likely are variations patient to patient, but in general, what we refer to is that the normal anion gap, the difference between cations and anions, and again, these are the ones that we're just measuring, it's not in total, is 12. Now, conceptually, this I think will help explain this a little bit better. So if we're talking about measured cations, again, the only one that we're measuring in this particular formula is sodium. When we talk about measured anions, we're talking about chloride and bicarbonate, but there are a number of anions that we are not really measuring or including in this formula, and that difference is approximately 12. So the anions that we don't typically measure and include in this particular formula are things like phosphates or sulfates or other organic acids, keto acids, lactic acid, serum proteins, things that will contribute to your anions, but again, we're not including in this formula, so that there is always going to be a gap between cations and anions. Now, let's just say that your patient has developed a condition, whether it's lactic acidosis or diabetic ketoacidosis, or maybe perhaps it's alcoholic ketoacidosis or uremia, lots of conditions that can ultimately lead to an increased acid load. So in this particular case, let's say our patient has a seizure and develops, at least briefly, a lactic acidosis from anaerobic metabolism. You have an addition of an endogenous acid, it combines with bicarbonate, releases carbon dioxide and water, and now you have a greater amount of unmeasured anions that are floating around your serum. So what you can see is comparing this to the normal anion gap, which is about 12. Now you have this excess ketoacidosis, let's say if it's DKA, or if it would be lactic acidosis, you would have, instead of keto acids, you would have an excess of lactic acid. But those are not being measured in the anion gap formula. So now you can see with this addition of lactic acid or keto acids into the serum that you have a much, much greater anion gap. And when you have an increased anion gap, that is significant for what we call an increased anion gap metabolic acidosis. Now, the next concept, just want to kind of get across, and this will make more sense as we bring these two concepts together, is something called delta delta. And what delta delta refers to is it refers to the change in your anion gap and how that compares to the change in your serum bicarbonate. And kind of the rationale here is that if you have 1 millimole of unmeasured acid, that's going to titrate 1 millimole of bicarbonate. So in effect, as your anion gap increases by 2, 4, 6, 8, your serum bicarbonate should decrease by approximately that same proportion of value. So the delta-delta formula or kind of ratio is important for us to evaluate anytime we're looking at a basic metabolic profile in a patient when we're evaluating them for the potential of an acid-base disturbance. And it helps us to identify whether or not there could be more than one metabolic process occurring simultaneously. So take a look at the relationship here, and I think this will make more sense. If you have an excess of unmeasured anions, whether it's again DKA or lactic acidosis or uremia, you will increase your anion gap from 12 to whatever it may be. So let's just say that you increase your anion gap and it's now 24. You take your sodium and you subtract that from a combination of your chloride and bicarbonate, and you get a value of 24. If your anion gap is normally 12 and now it's 24, that difference is 12. So in that case, you would expect your serum bicarbonate to decrease by that same value. So if your anion gap, let's say, goes up by 10 and your bicarbonate decreases by 10, that's consistent with an increased anion gap metabolic acidosis. Now, as much as this looks like a smiley face, it's not. Now again, normal anion gap is 12, and don't forget that your normal serum bicarbonate is 24. And you have to keep these normal values, you have to be aware of the normal values so that you can understand the changes that occur. So let's look at a couple scenarios. As we just mentioned, if the change in your anion gap equals the change in your serum bicarbonate, then that's consistent with an increased anion gap metabolic acidosis. Alternatively, and again, I don't want to get caught on semantics here, but these values may not change exactly. So if the anion gap increases by 10 and your serum bicarbonate decreases by 9, that typically is close enough. But if your anion gap changes by 20 and your bicarbonate only changes by 5, that's a huge discrepancy. So think of the next scenario. If your anion gap, if the change is much less than the change in your serum bicarbonate, and we're going to go over a couple examples that will make this, it'll visualize it a little bit better. So if the change in your bicarbonate is greater than the change in your anion gap, then that's consistent with what we call a normal anion gap or a non-gap metabolic acidosis. And alternatively, if the change in your anion gap is much greater than the change in your bicarbonate, that's consistent with a metabolic alkalosis. So let's go over a couple examples just so that people can I think, visualize this a little bit better. So here's a case. You see a patient, you walk into the room, they're telling you they're really not feeling well. They're a 34-year-old male with a history of diabetes, and the patient reports feeling weak and tired for the last couple of days. He reports he's had some polyuria, polydipsia. You look at his vital signs. He's tachycardic at 118. He is tachypnic in the low 30s. Blood pressure is a little bit on the low side also. And what you see quickly looking at his basic metabolic profile is certainly that he's hyperglycemic. And you see that his serum bicarbonate is much less than normal. Normal would be 14, and here, normal would be 24, and here that you see it is 14. And when you figure out the formulas that we just talked about, his anion gap, 139 minus 103 plus 14, so his anion gap is 22. Remember, with a normal anion gap being 12. So we know he has an increased anion gap. That is synonymous with an increased anion gap metabolic acidosis. So now what we also have to figure out is the change in the anion gap and how that really compares to the change in his serum bicarbonate. The change in the anion gap, 22, which is what it is now, minus the normal, which is 12, gives you 10. If we also look at the serum bicarbonate, normally it should be 24, but right now it's 14. So that change is also 10. Change in your anion gap equals the change in the bicarbonate. That basically tells you that the only metabolic condition going on right now is an increased anion gap metabolic acidosis. Now let's alter the situation a little bit. So we have the same 34-year-old male. He's not feeling well. He has a history of diabetes. He's been weak. He's been tired the last couple days. Same thing. He also complains of polyuria, polydipsia, but instead he's had multiple episodes of vomiting over the last 24 hours, 5, 6 episodes. Still tachycardic, still a bit tachypnic, blood pressure is a little bit on the low normal side. And when you briefly look at his basic metabolic profile, certainly his hyperglycemia stands out, but nothing else really jumps out at you that is abnormal. Certainly his serum bicarbonate looks normal. And if you do not figure out some of these calculations, you can absolutely miss the important details of this particular case. So let's go through it again. Let's look at his anion gap. It's 139. His chloride's 93. His bicarbonate's 24. Now his anion gap, when you figure it out, is 22. It's still elevated, and that will tell you absolutely that this person has an increased anion gap metabolic acidosis solely because that anion gap's 22. So when we figure out the delta anion gap, it's 22 right now. We take away the normal value, which is 12, and we're left with the delta anion gap being 10. Now when we look at his delta bicarb, the normal value is 24. His value today is 24. So that delta bicarbonate is 0. So there's a big difference here. The delta anion gap is much greater than the delta bicarbonate. And what that tells you is that there's some additional condition that's raising his serum bicarbonate about 10 points or so. And the only condition that independently raises your serum bicarbonate is going to be a metabolic alkalosis. So this particular patient has what we call a mixed acid-base disorder. He has an increased anion gap metabolic acidosis. We know that by the fact that his anion gap is 22. And by the fact that his delta gap is much greater than his delta bicarb, he has a second primary disorder, and that's a metabolic alkalosis. And in this particular case, it's coming from a loss of hydrochloric acid due to his excessive vomiting. Now, again, let's look at a slightly different case. You walk into a third room, maybe they're triplets. 34-year-old male with a history of diabetes, feels very weak and tired over the last couple of days. He also has polyuria, polydipsia. He's not vomiting this time, but he actually has had, a fair amount of loose, watery stool, multiple episodes over the last couple of days. Same vital signs. And when you look at his basic metabolic profile, again, you see that he is profoundly hyperglycemic. And, immediately I go right to look at this abnormal bicarbonate, very, very, very low. And when you go through the process of looking at, from a metabolic standpoint, and figuring out what his anion gap is and what his delta is, you have some abnormalities here. So his anion gap is also 22. And that tells you in and of itself that he has an increased anion gap metabolic acidosis. And his delta gap is 10. If you look at his serum bicarbonate, right now it's 4, with the normal value being 24. And his delta bicarbonate is 20. So in this particular case, this patient has a change in his bicarbonate, which is much, much greater than the change in his anion gap. So something else, some other condition is lowering his serum bicarbonate, but is not affecting his anion gap. And in this particular case, this is a scenario where a patient having a lot of profuse watery diarrhea is also losing a lot of bicarbonate through fluid losses through his GI tract. So this person, in addition to having a increased anion gap metabolic acidosis, in addition has a non-gap metabolic acidosis. Again, 2 separate primary conditions. And this and the case immediately before are consistent with a patient who has a mixed acid-base disorder. Now, if you want to look at this kind of next to each other in a table format, this I think also will help you understand this. So normal values, normal bicarbonate, normal anion gap, and with those values being normal, there is no delta anion gap or delta bicarb. And let's just use as an example, maybe a patient who's seizing who has lactic acidosis, or maybe a patient who has sepsis. And in this particular case, bicarb is 14, which certainly you would immediately identify as abnormal. And when you figure out this particular patient's anion gap, his anion gap is 22, his delta gap is 10, and his delta bicarb is 10. And that tells you that this patient only has an increased anion gap metabolic acidosis. Anion gap goes up by 10, bicarbonate goes down by 10. The ratio is basically 1 to 1. So the only metabolic condition going on for that particular patient is an increased anion gap metabolic acidosis. Now you add some prolonged vomiting to this clinical scenario, and what basically happens. The only value that you can see that really changed dramatically here is the chloride, and you're going to lose again hydrochloric acid from vomiting. And in this particular case, also your bicarbonate concentration will increase because of the loss of hydrogen ions from the vomiting. The anion gap is still the same, it's still 22. Because of that, the delta anion gap is 10, but when you look at the delta bicarb is effectively 0. Bicarb's 24, the normal value is 24, so there's some condition, in addition to increasing the anion gap, there's some other condition that's basically raising the bicarbonate back to normal, and that is due to a metabolic alkalosis. So this person has both an increased anion gap metabolic acidosis and a metabolic alkalosis occurring simultaneously. You take a look at the third case, similar to the DKA one that we just talked about a few minutes ago, but this person has, sepsis or seized and is having, lots and lots of diarrhea over the last couple of days. And in this particular case, again, take a look at the numbers. And you can compare them across this particular table. The numbers basically show you this guy has a profoundly low serum bicarbonate. His anion gap's 22, and his delta anion gap is 10. So I would think if this guy's delta anion gap is 10, his serum bicarbonate probably should be around 14 or so, but something else, some other condition is lowering the bicarbonate much, much lower than what it is expected to be. So this delta bicarb is 20 and the delta anion gap is 10. There's some condition lowering that bicarb much more than what it should be. And the only condition that will do that is a non-gap metabolic acidosis. So this particular patient has, again, two conditions going on. It's a mixed acid-base disorder. They have an increased anion gap metabolic acidosis, and you can tell that by the anion gap being elevated at 22. But in addition, there's a non-gap metabolic acidosis. Now the last kind of concept or formula here that we want to go over is something called Winter's formula. And Winter's formula is used to determine if there is appropriate respiratory compensation. So most of what we've just spoken about in the last couple minutes is really looking at a basic metabolic profile and trying to determine based on the anion gap and the bicarbonate whether there is one or more than one metabolic condition going on with your particular patient. Winter's formula is used when you have a patient who you've already identified has either an increased gap metabolic acidosis or a low bicarbonate, even if the anion gap is normal. But let's take a look at, DKA or lactic acidosis when you're going to have a low serum bicarbonate. When you check a blood gas, what you're doing for those cases many times are looking at the extent of the acidemia to try to determine what the pH is, but you're also trying to determine if there's proper or appropriate respiratory compensation. And as we mentioned earlier in this brief primer, is when you have a metabolic condition, there's respiratory compensation. And we're going to primarily focus, and the formula is primarily used for metabolic acidosis and the respiratory compensation that occurs with that particular condition. What you do have to know is that the normal PaCO2 value is 40. Now, if you have a respiratory compensation that is outside of the expected values, so if you look at this formula, the expected PaCO2 is 1.5 times your serum bicarbonate value plus 8 plus or minus 2. So if your serum bicarbonate, let's say, is 10, 1.5 times 10 is 15, plus 8 is 23, plus or minus 2. So if your bicarbonate is 10, for that case, you would expect your PCO2 on your blood gas to be between 21 and 25 millimeters of mercury. If your PCO2 is less than expected, so let's say instead of it being 21 to 25, let's say it's 10 or 12, it's much lower than what you would expect it to be. Some other condition is causing you to hyperventilate, which in acid-base terms really is consistent with a respiratory alkalosis. So maybe the patient has lactic acidosis because they're septic, and that also commonly will trigger your respiratory centers to improve alveolar ventilation. On the other hand, let's say someone who has DKA is obtunded because they're really so acidemic and acidotic, but they really are not awake enough to adequately ventilate, and their PCO2 starts climbing. So the case we just talked about, if your bicarbonate is 10 and you expect your respiratory compensation, your PaCO2, to be 21 to 25, let's say instead it's 35. That's much higher than what you would expect in that particular case. Although your PCO2, the normal value is 40, that's under normal circumstances. When someone has a metabolic acidosis from whatever, DKA or lactic acidosis or uremia or whatever it may be, then the expected normal is going to be different than 40. It really depends on the underlying scenario. So here's a good way to explain. You have a 34-year-old male, same case, diabetic, not feeling well, weak, tired, polyuria, polydipsia. You take a look at his basic metabolic profile. He's hyperglycemic. He's got a low serum bicarbonate. You figure out his anion gap. It's 22. You know he clearly has an increased anion gap, metabolic acidosis. You figure delta delta, the change in gap equals change in bicarbonate. There's no other metabolic process going on. You get an arterial blood gas. You identify or certainly confirm that the patient is acidemic with a pH of 7.28. And you're trying to determine whether or not there's proper respiratory compensation. So in this particular case, 1.5 times 14 plus 8 plus or minus 2, 29 is right smack in the middle of what you would expect the PCO2 to be in this particular case. So this is a lot of stuff to go over, and I kind of fully expect that you'll want to review this maybe one or two more times before the lecture. Take a look at the other resources that we provided for you at the beginning of the lecture. There will be ample opportunities to ask questions and kind of review things when we go over this in a bit more detail with some additional cases on February 6th. If you do have any questions, certainly feel free to email me. I would, I guess, prefer not to get 200 emails, but if you have a burning question and you want me to try to help clarify something, please feel free to contact me. Have a great day. Hope this makes sense, and I will see you on February 6th. Thank you.